Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my producer, Steph, and we are streaming live from the Moses Lake Professional Pharmacy Studio, as we always do every Thursday, 8 a.m. to 9 a.m. Pacific Standard Time on our midweek podcast. And don't miss out Monday, because we stream 12:30 to 1:30 on my personal Facebook page and the Moses Lake Professional Pharmacy Facebook page. And stay tuned, because the episodes get uploaded to YouTube. So subscribe to the Moses Lake Professional Pharmacy YouTube page. Today, you don't want to miss out. We have Matt Ohrt on today. He has been on before. He is a director of HR, and he has a experience with using direct primary care to save employers literally millions of dollars. So he's worked for a few big employers back in the Midwest, and he saved them millions of dollars by using direct primary care. And speaking of direct primary care, we have Dr. Shane Purcell on today, and he will be teaming with Matt to talk about how he, as a doctor, has helped employers save money. So if you or any of your friends are self-employed or know of an employer that is trying to save money on healthcare, which I think Matt a few weeks ago discussed that I think it's like 25% or something. Matt can go further into that later, but of an employer's expense is healthcare now. Don't quote me on that. Matt can clear that up, but it's a very, very big expense. And if you can save, 25%, it's a way to and help your employees. It would be a much better option. So tune in, share that with your friends, share this episode with your friends that are self-employed or know of an employer that is trying to save money on healthcare. So without further ado, Dr. Purcell, welcome to our show. And Matt, welcome to our show.
Thank you,
Thanks a
Shawn.
lot.
And
Good to be
Dr.
here.
Purcell, I'm going to go ahead and let you introduce yourself. You have not been on our show before, and tell us a little bit about yourself and the history of your DPC practice along with the name.
Sure. I practice in Anderson, South Carolina, which is in the northwest corner of South Carolina. If you draw a line between Atlanta and Charlotte, there's an interstate that runs between Atlanta and Charlotte. We're almost dead right in the middle. Upstate South Carolina. Been practicing here. I came and did my residency here in '99 and just stayed in the community. So I've been here for over 20 years now. Started out doing private practice for a couple of years, realized that continue to do traditional practice was just not going to work because of the paperwork and button clickings and all the stuff that you had to do. Just transition over to urgent care for a while, and then I opened up my own urgent care and primary care practice. So I've never really worked in the system, I would say. I've never been an employed physician, always worked for myself. And had a cash-only clinic in 2005 that I started, which was the only one in town. It was basically like going into McDonald's. You just walk in and you paid $45 a visit, and $10 for this, $10 for that.
Right.
It's the only clinic like that in our community. And, that's the way healthcare used to be. It used to be like that 100 years ago. So nobody was doing it back then. And so I did that for a few years and opened up an urgent care, and it kind of went out of control. We ended up having 4 or 5 providers and a bunch of nurses, and we were taking some insurance by then. We're seeing 60, 70 people a day. It just got super hectic. And I was getting further away from primary care, which is what my training was. And so that was about in 2012. I was trying to get back into doing more primary care, and that's when direct primary care was starting to take off.
Mm-hmm.
We were starting to get some technology that was helpful for direct primary care, certain EMR systems and mechanisms where you could do a lot more video visits and telemedicine and texting, and the technology got real advanced. So looked more into doing urgent care, to transition away from urgent care to doing more primary care again. And we opened up our direct primary care clinic in 2015, and I transitioned away from full direct primary care in 2016, January 2016, and basically been focused on direct primary care since then. Here in Anderson, we're the only direct primary care clinic in our community of about 200,000 people.
Wow.
We're up to we have 4 physicians and 1 PA in our clinic now. and each physician or provider has their own medical assistant. So we have about 12 employees, and we're currently slowly adding people, but we have a massive waiting list because there's so much demand in our community. And along with that demand, and hopefully Matt can speak to this, is the more and more employer demand as these prices and fees and everything gets out of control. Everybody's tired of getting those 8 to 10% raises every year on their premiums. More and more employers are looking at, hey, I need a different way to do this. Many are looking at the self-funded options on how to go about doing that and matching that up with, third-party administrators, TPAs that are really good at working self-funded plans, but also trying to partner up with direct primary care clinics in communities. We actually partner with a couple of clinics that are in our general community, not necessarily in our same county, but we have others in the next county over that we partner with. And so if we have our large employer, we will feed out, we'll do a contract and just try to get people opportunity to, you can go to this clinic here, which is 30 miles away. You can get this clinic in our town. So we try to partner with other DPC clinics and really have sort of like a mini network for that employer, which has worked out pretty good so far.
Well, thank you for what you're doing. And considering you have 5 providers, you said, I think, and you're obviously growing. It's a testament to how well DPC is working, and it's also a testament to that it's not going away. In my opinion, I think DPC is the future of medicine. We'll still have traditional medicine. I don't think we'll ever get away with that, whether we want to or not. But DPC is definitely here, and thank you for what you're doing, Dr. Purcell, because patients are really grateful for that, and employers are too. So thank you so much.
Oh yeah, it's been a great ride so far.
Yeah. And so, Matt, tell us a little bit. You heard Dr. Purcell's story, and tell us a little bit about how you have worked with DPCs, being the head of employers to save them on healthcare. How have you worked with DPCs and integrated them into an employer's healthcare plan?
Sure. Well, I've got about 23 years progressively in human resources type roles, and most recently, before my current role, I was the VP of HR and Medical Services for a company called Merrill Steel in central Wisconsin. And the medical services was actually added to my title after we delved into it and had great success. So the perspective that I speak from is an employer perspective, and it's one out of frustration that I think many employers have, in that you start to look at your medical cost, and you had mentioned it, a 9% increase for about 20 average nationally for about 20 years in a row. It's really not sustainable. It's becoming unaffordable, and we've seen employer plans degrade more or less to where they're just catastrophic plans. You pay a lot out of your paycheck, and then you have huge deductibles typically after that. So you're really avoiding healthcare, or you're certainly, if you are getting healthcare, you're paying far too much for it. So we had started off with an on-site. Was in our case, we had all of our employees were kind of together. We did another one later at our 2 locations, so we had both. We started off not knowing much. Pretty much what I know about this topic is all learned from conversations and experience. I don't think there's a textbook on it. Maybe we should write one, a book on it.
But we'll get into that later, won't we, Dr. Purcell?
There you go. Yeah. So
he has a book about that.
Okay. Yeah, and I think this conversation should be very fascinating today, because it's blending that DPC expert with probably a somewhat unique and maybe growing employer experience. It stems from the notion we shop for everything else in life. We shop, I try to shop local, but I mean, you shop on Amazon, you got stars for quality and you got cost. If you go to the local car lot, you got your brands that you trust and you don't, and your prices and so forth. But if anywhere we're shopping, whether it be a TV or a car or you name it, we go Christmas shopping. If we don't like the deals in front of us, we see a price, first of all, which is nice. But if we don't like the deals in front of us, what do? We shop elsewhere. And so I think the DPCs are are springing up all over America because employers and the narrow network and the kind of in the 40% off of the unseen, invisible, moving charge master numbers is not acceptable anymore. So as employers are waking up, they are here in central Wisconsin. I lead a best practice group, and it's nothing fancy at all. It's a collaboration of employers who are trying to do better. But I think, and we have a meeting next week with some employers who are very interested in starting a DPC, typically near sites. So I think that gives us the opportunity to shop elsewhere. And when you shop elsewhere, then it wakes up those that have monopolized or have all the business but haven't had to perform for it. They're not working on efficiencies, they're not working on quality, and they're raising prices arbitrarily.
Dr. Purcell, can you speak to that as far as transparency in DPC pricing and quality, even though the price is a lot less than what a local big healthcare corporation entity or hospital is? Can you speak to that?
Yeah. Well, I mean, how much time do you guys have? I mean, Lord,
you've got the floor.
The truth is, and hopefully Matt can back this up, because he has probably actual numbers and data that he can probably look at from previous businesses where he's worked at. But and many wise advisors and brokers, whoever you're working with as your employer, that are setting up, really crafting unique plans that work with DPC, either on-site or local DPC, and are using smart TPAs, and they're using self-funded plans that are wise. Many will tell you in your community their hospital systems, and the most expensive hospital systems are usually have the least quality. So in healthcare, quality and price are inversely related, which is very unique. So there's a good chance in your community the hospital that's charging less is probably providing better quality. And there's ways to look at that data and get that information. So we kind of focus on price a lot. We're pretty adamant and about getting the best price for our patients, whether it's medications, labs, imaging, those kind of things. Half of our patients are individuals, right? They're not coming here through an employer. So for the most part, they're paying out of pocket. And even our employed patients still have copays and deductibles. So if we think we can get a test, a chest X-ray, or anything that's cheaper than their copay or deductible, we're going to say, hey, you could go here and pay $40 or you can go here with your insurance and pay $100. You might as well just go here and pay $40.
Right.
So we're always looking out for the best interest of the patient, which includes financial interest, right? So it's not just do no harm, medically, it's also do no harm financially, right? So if I write an order for a prescription that I know is going to be $800 a month, and I send them to the pharmacy, but they can't afford that $800 a month, have I really helped them in any way? So it's not been really helpful. So we really have to be smart about the things that we write for prescriptions, but also working with local companies and employers that can use that have lower cost. And sometimes that can be tricky because you can't get that information. Like if you're working with a hospital system, I'm sure Matt can speak to this, trying to figure out, what does a CAT scan cost me? What can I get a CT scan for? Well, it depends on what day it is, and
right.
Depends on who's in charge that day and how it's coded. So those things, trying to work with independent pharmacies is good. Working with independent imaging centers is good. Avoiding hospitals as much as you can, because that's where they drive up cost. So that's where we try to work with employers to say, hey, here's the places that we work with that we know we can get like an individual good prices. So we're hoping that you guys can get good prices for your employees too.
So Matt, can you go ahead and piggyback on that and kind of talk about some of the ways that you have, talk to the big systems, and then also the more independent systems where you save lots of money on, like MRIs, for instance? I know you have a good story about that.
Mm-hmm. Yeah, it's amazing how much our statements and our conversations are the same. I use the same phrases, and the do no harm is a big one, right? I think Wisconsin's pretty decent for quality, but our cost is one of the worst. And there's a lot of things that I learned along the way. I guess it actually makes me laugh when I look back at the proposal that I put forth for the DPC that we started with. I mean, it was innocent and it was good intent, but it was naive in many ways. But one of the things with that is having the courage to try, because we already know what we have. We have invisible high prices that come later. And we have, look at the typical visit. It's 15 minutes. It's a hamster wheel. It's cranking them out. There's very little time for care, relationship, and conversation, old school medical care. And that was very effective. And so it's become this churning system. And all there really is time to do in that 15 minutes is refer. So, when we started off, when I first started learning about these, I thought, well, we'll save money on primary care. And that should be true. The worst you should do is break even on the cost of primary care. Dr. Purcell indicated many of the next wins, though, and I would argue that the next wins are the big wins. So once you have the gateway, once you have the relationship with the DPC, whether it's on-site or near-site, I don't think it matters that much. If you have to partner with other employers, if you're not big enough, partner with other employers and do a near-site. But it's that interruption, if you will, whatever words you want to choose, the interruption of the referral process, because many of the referrals within the system, many are incentivized to refer. Many of those referrals are unnecessary altogether, first of all. So we're only going to do necessary referrals. But then the strategy that we took was interrupting the highest costs of healthcare. So looking at the claims, the top 5, and there's some other things too, but the top 5 were imaging, orthopedics, oncology, cardiology, and NICU. But also looking at other things like blood work and labs. We could send those directly to Quest, which many of the systems even send to Quest. But we found in the examples we saw, the markup was 1,000 to 1,500%. That we could just send them to Quest ourselves through the DPC. Same tests, same companies even. The MRI, Shawn, you've heard that example where we put in a plug. We wanted to interrupt the imaging. It comes before the orthopedic and bundling. But we put in a plug, and now we're seeing those plugs being put in even by the companies in town. But you can get an MRI and a read for around $600. Some places even less in bigger cities, but $600. But if that same driver and that same tech gets in that truck and then they drive and they plug in at the hospital system, the charge magically becomes $5,000, give or take. Now that MRI company is still making $600. They're not making any more. They just plugged in and somewhere else. But that doesn't sound like what the right intent for a nonprofit community hospital should be. If they're that efficient, then they should work on efficiencies. But that's not fair to the consumer, because there's no value in that markup of 44 or whatever that number is, but give or take $4,400.
And one of the things from what I've learned is that a DPC doctor, and Drs. Purcell, you can talk to this, is good at finding those places where a patient can save money. So I'm assuming, Dr. Purcell, you have a way to really save patients money on labs and on imaging. Is that correct? Because you know where to refer them to and where not to refer them, correct?
Yeah. So we have a local imaging place that we use, and then we have some actually imaging places that we have in the next community over that we'll use too, that we know where we can get ultrasounds and echocardiograms and things for $200, $250 echocardiogram of the heart, which is about a quarter to a third of what it is at the local hospital system. And it's read by cardiologists, so it's a good test. And then we do all our labs in-house, sort of, as Matt was saying, sort of the same approach. We have an incredible contract with LabCorp, which is the competitor to Quest, the major competitor, but we get, it's ridiculous what we charge our patients. It's so, you can do a CBC blood count test for like $2 is what we end up charging our patients. A thyroid test for like $3 or $4.
Right, and that's incredible. $2 for CBC. Will you give an example so our listeners and viewers know what would that same test run at a hospital? What have you heard?
Well, in our hospital system, the last time I saw it posted, they would run cash pay prices, and it'd be like $30 for that same test, which is not terrible,
No.
but that's a massive markup, because that test, in my opinion, I'm sure the hospital system can run that test for 50 cents, maybe less. And so most of those are going to be $30 to $40. Now, if you bill them through insurance, like if you did like a lipid panel might be billed at $150 through insurance. Now your employer's only going to pay maybe $15 of that, or whatever the final payment may be 15, but it's going to be billed out massive amounts. But we could do it here, and our large employer that we work with, we just do the labs for them here because it saves them so much money, massive amounts of money, than trying to run it through their TPA and then trying to pay that later. So we just do a lot of the labs here, and we do a lot of the generic medications through our clinic as well, just because we can get them so cheap.
Well, and the reality of it is, every pharmacy can get them cheap too. It's just they don't know how to bill for cash anymore. Most pharmacies deal with insurance companies, so they charge something that should be $5, they charge $50, even though the insurance doesn't pay them that. It's a complete racket, and it's got to stop. And that's why we really have to train employees or patients that paying cash many times for routine services, whether it be lab work, whether it be a doctor visit, or whether it be even certain imaging, especially if a high deductible, it's just better to pay cash. Because then there's no surprises too, right?
Yeah, for sure.
So Matt, tell us how would a DPC, what is the best way for a DPC to approach a fairly good size employer, you being in that role, a fairly good size employer, to say, hey, I want to start, we have some ways to save you money. What's the best way for a DPC clinic or doctor to do that?
The DPCs that I've worked with and what I've seen, and it's great that, that you can get the community thing going, because I've seen that in the bigger areas. Where they can serve both the community and then partner with an employer. In our area, the ones that and they're just starting to pop up in a lot of places in Wisconsin and across the nation, but is to work directly with an employer. And there's different fee models that can be done. Fee for service is an option. It's not as common, but it's kind of a safer start if you can keep it really simple, right? We don't want to bog down the DPC with administrative work and costs, but it's safe because you only pay if you use it. You can open it up to all your members. There's a blend model where maybe it's a low PM, that's per member per month per belly button, and then maybe some additional charges for certain services. And then there's probably the most common is all in, where you're paying good rates. I've seen maybe $50 PM, but they can go all the way up to 90 or more. So, I think DPCs also have to be careful in terms of what they're charging, because we don't want to go animal farm, as I call it, where we start out with good intent and then 10 years later, we're just as corrupt as the original system.
Right. So who would be the contact person? If a DPC doctor was trying to network with an employer that's a bigger size, that has maybe multi layers of management, who would be the best person for the DPC doctor to go to?
Shawn, what I found, and Dr. Purcell may have an opinion on this, but it's maybe not a title, because you're looking for a person who is maybe more action oriented. A lot of people like to be second. Not a lot of people like to be first and be the first one to try something and see if it works. So kind of the mavericks, and I mean that in a fun way, in the company. I've seen that as sometimes it's the owner of a private company. Sometimes it's the CEO. Sometimes it's the CFO. Sometimes it's the HR person. So I think you maybe need to find out who's the person at the respective company that's aware of the cost. That's the first step. A big gap in this, and I would argue maybe the biggest gap in all of this, is employers, the payers of that side of healthcare, right? Half of it is paid by the government roughly, and the other half is on the commercial employer side. that are paying these costs. So you had mentioned at the start of the show, right? It's an employer's typically second, almost always second or third highest cost. And we'll manage purchasing. The purchasing department will manage materials and supplies and so forth, equipment down to the penny. And they'll negotiate hard all day long. That's what they do.
Right.
But yet we'll get out the checkbook, and self-insured employers even will write $1 million checks and think nothing of it, and not question whether there was, right, another quote, another option, a chance to shop, whether the price was fair, etc. So one of the big steps, and that's kind of my drive right now, is helping employers in the area, finding those people within those respective companies who are frustrated and are aware and willing to do something about it. Because if that group doesn't act, we can have all sorts of DPCs everywhere, but they'll sit empty. They'll sit empty and they'll sit idle. And it's the employers that need to initiate a lot of these steps.
And Dr. Purcell, you kind of wrote a book about this, correct?
Yeah.
Can you tell us about your book?
So the book is called Magic, Pixie Dust, and Miracles. And it's basically, it's two-sided, really. It's about our journey through DPC, working with employers specifically, and how that came about. And then and lots of tips and for DPC doctors to how to connect with employers, but also lots of tips in there for benefits advisors, where we're coming from DPC, because as Matt mentioned earlier, we do not want to certainly end up 2 years from now going back to a fee-for-service type field where we're doing the same kind of work we were doing before. Well, we need all these codes and bills put in. We need you to do prior authorizations. We need you to do this. So we're right back where we started, only spending 10 minutes with a patient, which is not what we want to do in direct primary care. So it talks about our perspective, where we're coming from, and why we did DPC, why it makes sense, and then how employers can connect with DPC physicians. I'm a founding member of the DPC Alliance, which is a national organization of independent DPC physicians across the country, and we have about 500 members or so, and half of those are residents and students, which we love because we want them to pursue primary care with the insight of doing independent direct care practice. But we have tons of DPC docs across the country, and we're doing classes and training and learning, sort of like Matt's saying he's doing with employers. We're doing the same thing with physicians, trying to rescue them out of the system that they're burned out, frustrated, and ready to quit. And so if we don't try to rescue some of these physicians and show them that, hey, direct primary care is a good way to go, and there are employers that really want this service, they may not realize it or understand it, but there are employers out there that really could use this service. So the book is a lot about that, our steps, how we did it, how we connected with a benefits advisor, how we connected with the employer. And the number one way, obviously, to connect with an employer, and Matt sort of touched on this, is basically almost all of our connections are people who see us already in our practice. They're a CEO of a company, and they're our patient already, and they say, hey, I want to take this to all my employees. Or we have a high-level employee. Our connection that we had with our county, which is our largest employer, was a high-level employee that worked for the county administrator, was our patient. And he kept saying, listen, you guys need to think about doing this, because I have our own insurance, and I still pay to go here because it saves me so much money. And so he kept getting in their ear, and then finally we were able to talk with him. It was 3 years for us of talking and thinking about things, but it's a municipality, which is a huge ship to turn around.
Right.
Number two, this municipality had been on the same BLUCA plan, insurance plan, for 20 plus years. So to drop that plan and go self-funded was a massive, massive undertaking. And, all these people were responsible. Most of them are county council people, were voted in. So there's a lot of politics in that. And it's big money when you're talking about, it's a $10 million change, because they were paying $10 million every year to Blue Cross. And so, and they were getting zero data. They had no idea where the money was going. And so all that's discussed in my book about how we work with this employer and how that settled out. But there's a lot of tips in there about trying to connect with employers and connecting with brokers or advisors. I call them advisors. You want an advisor is critical. You have someone that understands what Matt's trying to do, which is save money and get the best care for his employees, and what we're trying to do, which is try to take care of employees without costing a lot of money. You got to merge those together, and there's a lot of magic, pixie dust, and miracles to make those three
Right.
things come together. You got to have a willing physician that wants to do DPC. You got to have an employer with the courage to say, hey, I got to do something different. And you got to have an advisor that can put all that together to make it work. It has to be a self-funded plan with a TPA and a stop loss insurance, and all the things have to come together to make sense. And that's kind of what the book is about.
That's awesome. Well, thank you for sharing that. And we do have some comments on Facebook. Let's see if there's any questions. Actually, it just looks like some comments, but there's a person commenting that they got an MRI, $145 for cash in Idaho, rather than going through their
Man,
insurance. Yeah. And there's just some stories they're talking about on that. So people really need to know that they can be better off many times paying cash and using a DPC doctor or their primary care doctor as an advocate to tell them, where the best place to go is. So, Matt, can you kind of sum up our podcast as we kind of wind this up? What would in a couple sentences, what would be the easiest way if a doctor was trying to go to an employer to save money, and they were trying to get a hold of you? What would be the easiest way to get to you? And I know you already know the details, but if you didn't know the details, what would be the easiest way to get in the door and get you talking?
If I were in the DPC shoes, and because I know the employer shoes well, I would maybe they call them roundtables, they call them summits, but gather employers together and talk about these things that, as we've talked about for years, are somewhat obvious to us, are not at all obvious. I signed that paper many, many years in HR without, right to the narrow network, and signed away our ability and all my employees' ability to shop without really being aware of it. Right? None of us would go Christmas shopping and fill up our cart with toys and products that were on shelves that were not marked and then say, just send me the inflated bill later. None of us would do that. We would shop elsewhere. So I think as DPCs give us an opportunity, they give us the gateway. They're not the end solution. They're the beginning of the solution to shop elsewhere for MRIs, for orthopedic bundles. And so DPCs are the gateway to do that. I think it's going to be big if employers are willing to move.
Yeah, it already is big, and I think it's just growing even more. I think it's going to create a revolution in healthcare, because there's definitely, when you're talking about what you're basically talking about, Matt, shopping, it's free market. I mean, every other industry that we deal with, whether it be buying a car, buying a TV, or even buying a house, there's a free market involved. With healthcare, it's just usually not that way. Patients are usually told where to go with their in-network programs based on their employer or based on some government system. And so price can go up, quality can go down, service can go down, and the people are just stuck. It's really created a monster and a monopoly, really. So we want people to be free to choose their own doctor, to choose their own services, and how much they're willing to pay.
It's amazing. It's amazing how it's happened. I mean, I always say, if a problem goes on long enough, we don't see it anymore. Through school for about 7 or 8 years, at the age of 19, I started a construction business and grew it. And then I got into my career after that. But I used to do a lot of roofing. And for instance, I would never imagine showing up to someone's house and not expect to give them a quote on a new roof.
Right.
And if the roofer shows up at your house, and you would never expect to say, put on the roof and, just send me the bill later. And so some of the things that just confuse me, we do every day in healthcare. So I think we need to wake up and get a new perspective and see a problem that's been there a long time and is only going to get worse if we don't act.
Absolutely. Yeah. And it's not sustainable. It's really not. Like you were talking about earlier in the show. I mean, an 8 to 9% increase a year is not sustainable. No way.
True.
Dr. Purcell, as we wind this podcast up in the last couple minutes, what would you like to tell employers about why they should use a DPC doctor? What's the best way for them to feel comfortable doing that, getting out of the book, as we call it?
Right. Well, I would say, I mean, there's several different ways you can search for direct primary care clinics in your area. There's a website called dpcfrontier.com, dpcfrontier.com, and it has a map there because you can see who's doing direct care in your area, which is helpful. You can contact them and say, hey, let's talk about this. Also, our DPC Alliance that I'm a part of, dpcalliance.org, we have a strong list of independent direct primary care physicians across the country that you can connect with, and team up, meet up, and see how you can help each other. Those are big things. I think being a part of larger organizations like Free Market Medical Association can be helpful, where you can meet other advisors, benefits advisors, brokers, other employers that join up. Going to some of those conferences can really be helpful. And then really trying to find, this is tricky, but trying to find that benefits advisor that understands where you're coming from. It's helpful. And if you're a DPC physician, trying to reach out in your area to look at, who's doing real hardcore financial savings for employers in the benefits advisor arena, because most of them are just looking for their commission. They're looking for their bonuses, and they're not doing the hard work. And I'm sure Matt would agree with this. This is not easy. I mean, it's hard work to save that money, but it's worth doing. And I think from an employer standpoint, I think whoever's in charge of the healthcare system it should be a CEO level position. It should be, you're the chief medical officer for your company, and that does the CEO level work. And it's that critical especially for a larger employer. If you got 500,000 employees, you're talking about massive amount of money. And you'll have a CEO who's responsible for everyone, but somebody needs to be responsible for that financial responsibility of healthcare. And it doesn't need to be the CFO. It needs to be somebody else. Because many times it's just the HR person, and we don't have HR people like Matt that really care about it. They're more like, hey, you know what? I don't want to deal with this. I just want to sign this paper. Let's renew. Let's go and get this thing done, because it's such hard work. So it takes courage. I would reach out, if you're an employer, reach out to DPC, look for those DPC doctors in your community, and get to know them and try to see if that's a deal and a way to work together.
So, Dr. Purcell, what do you have a passion for? What drives you?
So, I mean, obviously, in our clinic, we have a passion for doing direct care, because the biggest problem is as a physician, we've lost our original oath that we had 20, 30 years ago, to basically take care of patients. And what happens is the system basically sucks that out of you. It sucks your oath away, where you really can't take care of patients. You can't have that patient relationship. And the only way to take good care of people is to have a relationship. It doesn't matter if it's your wife, whoever it is, your kid. If you have no relationship, you don't have time, which is number one. And if you only have 8 minutes to see your patient, you don't have time to really help them. You certainly don't have time to evaluate a shoulder and maybe prevent an orthopedic referral. So we need time so we can build relationships, so we can really make a change. And those are things where most independent DPC physicians, I would say, are really passionate about patient care and getting back to our oath and doing what's right for patients. Those are the big things that really keep us going every day. It just makes you want to get up and put your pants on every day and go to work and help people.
Amen. So tell us where where people can find your book.
So the best place is just Amazon.com. You can just look up Magic Pixie Dust and Miracles. There's not many books out there by that name.
No.
You can also find it on our website, directaccess.md. There's a link on that page for my book. I think it says Dr. Shane's book, and it just connects you over to Amazon. So you can find it there. And a lot of employers have found it helpful. I've got several benefits advisor friends across the country that they just keep copies of it and they pass them out to employers so they can get a feel where we're coming from. And they pass them out to their benefits advisor friends. So it's good just to get a feel of where we're coming from, direct primary care, and how we can help each other. It's basically how we can help advisors and how advisors can help us and how employers can help us and how we can help them. So everybody's looking for the win-win-win, right? So that, that's what we're looking for, this miracle of a win for everybody.
All right. And Matt, if from an employer side, if anybody has any questions, what's the best way to get a hold of you?
Yeah, my email is matthewohrt73@gmail.com. That'd be the best one to reach me.
Awesome. Well, you guys have definitely realized our goal today of Health Solutions, and that is to educate and empower individuals to take charge of their own health. And as we've said before, and as both you guys have said today, financial is very important in that, like it is in any other decision of something we buy. So not only just be proactive in your own health, but also the financial portion of it. So thank you guys very much for realizing that goal of educating and empowering individuals. I really appreciate it. And on that same note, one of the ways that we can save money on healthcare is definitely direct primary care. Also, one of the other ways, and I talk about it in my book called Sickened, How the Government Ruined Healthcare and How to Fix It, is to have a health sharing program. And we will have Jenny from Sedera Health. She will be on our podcast Monday from 12:30 to 1:30 Pacific Standard Time, and she will be talking about why you should use a health sharing program over traditional health insurance. And that and DPC alone can save thousands and thousands and thousands of dollars per year that you have in your pocket. And then you can direct the money where you want it to go, and you also get to choose your own doctor. So that's a plus win-win. So stay tuned for that. Jenny with Sedera will be on 12:30 to 1:30 with Health Solutions with Shawn and Janet Needham. And always, we appreciate you tuning in today. Listeners and viewers, please tune in Monday. You've been listening to Health Solutions with Shawn and Janet Needham. Thank you so much.